You know, this talk had evolved to be my favorite talk. I think the cyst talk was my favorite talk because there's so many cool tricks we have to evaluate cysts, but over the years this evolved to be my favorite talk, but then Z11 went and spoiled it all. So but I still think it's important to know about lymph nodes, and the truth of the matter is university surgeons have tended to follow Z11 hook, line, and sinker, and so my friends in the universities tell me they hardly look for them at all anymore. But most of my friends in private practice have changed very little. The surgeons say they don't trust it, they don't think it's definitive enough, and they didn't want me to change much of what I did, you know, maybe try to desensitize myself ever so slightly, but basically my surgeon in Santa Rosa said, don't change anything, I like the way you're doing it. So there's a lot of variability in how Z11 has affected us, and you know, to date it hadn't affected us very much, but I know some places have virtually stopped doing it. All patients that we have with BI-RADS 4 or 5 lesions in whom we're going to do an image-guided biopsy, we evaluate the axillary lymph nodes, and we'll perform a core biopsy on abnormal lymph nodes that we think are suspicious for metastatic disease. We obviously don't biopsy normal nodes because a negative biopsy of a normal node is worthless. But we also try very hard to distinguish the best we can between what we think are more likely to be reactive or more likely to be metastatic nodes. And really that's the value added to the performance, because a core biopsy of a reactive node is just an extra procedure that hasn't done anything useful. And are reactive nodes common in cancer? They are. Why? Because cancer is a foreign body. So you get your nodes react to it. It's an immune response to the cancer. They're very common in cancer. And again, Z11 has only slightly changed what we do, but I know there are places where it's had a radical effect. Ultrasound is the best examination for lymph